Hi, welcome to another episode of the UCLAMDChat webinar series. My name is Dr. Justine Lee. I'm a craniofacial and pediatric plastic surgeon in the Bernard G. Sarnett Endowed Chair in the Division of Plastic and Reconstructive Surgery at UCLA. And today I'm going to talk about Pierre-Robin sequence. So during the talk, feel free to ask questions on Twitter using hashtag UCLAMDChat or comment on Facebook. So let's get started. So the goals of this talk is basically to define what is Pierre-Robin sequence, to talk about what you can do for your child if he or she has Pierre-Robin sequence, to talk about what is internal mandibular distraction, which is one of the primary treatments for Pierre-Robin sequence, and also to talk about what are the associated long-term consequences of having Pierre-Robin sequence. So starting with what is Pierre-Robin sequence. This is a typical kid who has about a moderate version of Pierre-Robin sequence. And the defining characteristics is this micrognathia, or small mandible. And basically what that means is that this kid's lower jaw never grew very well in utero. And so now he's coming out, he's got the small mandible, and what happens is the tongue is actually connected to the mandible. So the tongue then falls back and actually obstructs the airway. So basically by having a small mandible, this baby is having the tongue in the airway and almost suffocating himself. Now, this comes in a variety of flavors. It can be kind of on the mild side, it could be in the moderate side, it could be in also a very severe situation where the baby is intubated in the neonatal ICU and really having a hard time breathing without having a tube in. So sometimes Pierre-Robin is also associated with cleft palates. Now the cleft palate happens to be in this kind of U-shaped version, and this is only sort of relevant to all of you parents out there who may have a child with the cleft palate. Sometimes cleft palates are described as a V-shape, sometimes cleft palates are described as an U-shape. U-shape basically means Pierre-Robin sequence. This cleft is pretty wide. And we're not going to talk about cleft palate today because I really covered that in the Cleft 101 webinar, so you can refer to that if you have any questions about treating cleft palates. So this is a frequent but not always portion of having Pierre-Robin sequence. So the incidence of Pierre-Robin is not super common, but I think this actually probably has to do with a little bit of underdiagnosis. So typical cleft, that's the most common cleft and craniofacial anomaly that one can have, 1 in 700. Pierre-Robin sequence, 1 in 8,500 to 1 in 14,000. It's isolated, meaning not syndromic, in about 58 to 70% of cases. And when it is associated with a syndrome, the most common syndromes are Stickler syndrome, 22q deletion, which is also called velocardiofacial syndrome, or DeGeorge syndrome, Treacher-Collins syndrome, Nager syndrome, and cerebrocostomandibular syndrome. So we're not going to go into great detail about the syndromes, but basically the constellation of micrognathia, glossoptosis, airway obstruction, there's kind of one unifying concept of how to treat this, and that's basically to go after the airway obstruction because that's the most immediate functional issue. So functional issues, as I mentioned, neonatal respiratory distress, frequently accompanied with feeding issues, frequently accompanied with reflux issues. So that basically means acid refluxing up and causing some more irritation in the airway, also causing some feeding issues. So let's talk about respiratory distress. So this is what we call sternal retraction. So you can tell this baby is basically sucking in air, and his sternum is coming back, basically retracting in because he's having such a hard time bringing air in. This is something that you would see in Pierre-Robin sequence. So you think your baby may have it, what can you do? Well, if he or she has a very severe situation, then he or she is already in the neonatal ICU and treatment is probably already going forward. So I'm talking about those situations that are more mild or moderate. Maybe it wasn't noticed in the hospital, maybe you're home now and you're noticing something's a little funny here. Maybe the jaw's kind of small, maybe he's having or she's having a little bit of trouble breathing. The first thing you do is do prone positioning or side positioning. Basically that means head down, face down, or on the side. And the reason is because, again, the tongue falls back and suffocates a child. So put the baby face down. If you notice that this is improving, time to call your pediatrician because this is probably a situation that needs to be monitored to come up with a treatment plan. If it's relatively mild, it might just be home monitoring just to make sure that no desaturations occur. and observe very carefully, because sometimes this is a situation that doesn't happen all the time. So you may not see sternal retractions all the time. Maybe it gets worse at certain times of the day. Maybe when the baby is more tired, that happens more. Maybe the baby is doing this more in the sleep. So those are things that as a parent you can do. Pierre Robin sequence is not always diagnosed because it's relatively rare. And that's what I mean by sometimes it could be underdiagnosed. And also sometimes certain things don't always get picked up in the hospital if it's not happening all the time. So let's talk about how we approach Pierre Robin sequence, specifically targeting neonatal airway obstruction. So when we see a child who has a small jaw and has airway issues, we first decide, is it mild or is it severe? If it's mild, as I said, home monitoring, prone positioning, so face down, and sometimes something called a nasopharyngeal tube can help. This is kind of a tube that's inserted through the baby's nose, and it just kind of helps keep the airway open. There's no anesthesia for this. This is done sometimes. Kids go home like this, and it's more sort of an older method of doing things, but certainly very effective. Now, what if we're in the severe realm? So if we're in the severe realm, if this is really bad, then we're looking at a sleep study, a milk scan, and direct laryngoscopy. And what does all this mean? So when we do a sleep study, what we're looking for is whether this apnea or the inability to breathe is due to something that is obstructive or something that is central. If it's central, it means the brain is telling this baby to not breathe, or the brain is preventing the baby from breathing normally. In that case, the baby needs assistance. We need to go to tracheostomy. Tracheostomy is when an airway is placed surgically in the throat, and basically a baby can be ventilated indefinitely with that airway. Mandibular distraction is a procedure that lengthens out the mandible, and that's what we use when we're dealing with obstruction. And so by lengthening out the mandible, we bring the tongue back, we bring the mandible into a more normal anatomical position, and the baby's able to breathe a whole lot better than before. So what about a milk scan? So a milk scan is when the baby takes a little bit of milk, it has a little bit of a tracer in it, like a little radioactive tracer, and we do some imaging with that, and we basically are able to decide whether or not there is reflux. So is it refluxing back into sort of the upper airway from the stomach? And if there's severe reflux, mandibular distraction is not going to be enough. What happens is we may distract out the mandible, but the reflux is so severe it's causing a lot of airway edema, causing a lot of other issues. Airway is still not so good. There's still problems with breathing. In these types of situations, we really need to consider other gastrointestinal procedures, which is a little bit beyond the scope of what we're talking about today, but that involves reflux procedures. Now, if the reflux is relatively mild or manageable, and distraction and obstruction is still due to the small jaw, mandibular distraction is a great option. So lastly, direct laryngoscopy. So while sleep studies and milk scans are done outside of the operating room, a direct laryngoscopy is done inside the operating room, usually with us prepared to do a mandibular distraction, provided that the direct laryngoscopy results are optimal. And what I mean by optimal is that there are no other airway lesions, that we're isolated to just the upper airway. The tongue and the epiglottis is your primary problem in terms of collapse of the upper airway. That is a prime candidate for mandibular distraction. Now, if there's multi-level lesions, like there's a tracheal problem, there's laryngomalacia that's very severe. When you're having those types of issues, then we're looking at a tracheostomy, because the mandible only, or the mandibular distraction only addresses the upper airway. So let's talk a little bit about what is this mandibular distraction thing anyway. So just a disclaimer, we're going to have some surgery videos, so if you're a little scared to see surgery, then maybe look away. So a lot of parents ask me this question, and this is really a reason why that wanted to kind of clarify what is this all about. So the concept is very simple. We're just going to lengthen out the mandible because the mandible was never the right size in utero. And so the way we do this is we start with the baby. Here he is on the table. Here's the mandible. That's the dotted line here. This is the incision that we make on the skin. Once we make this incision, we're going to go to the skull and make a cut in the mandible and then stretch it out a millimeter or so at a time. So it's exactly what it sounds like. We're just basically stretching it out, and the baby actually reforms the bone, and by the time we're done with distraction, the bone is relatively solid. Okay, and so here's a 3D CT scan. Here you see the micrognathia. You see how this mandible is so small compared to the rest of the skull. What we're going to do is we're going to make this L-shaped cut here on this part of the mandible. And in the operating room, this is our L-shaped cut. Okay, and once we're done making this cut, and here's the inferior border. So here's the ear, the baby's head is facing this way, or face is facing this way. Once we finish making this cut down here in 10 seconds, okay. Okay, then we're going to move on and put a distractor on. So this is what a distractor looks like. This is a turning arm. Okay, so this actually controls the distractor. Here are the two plates of the distractor. So the bone has been cut here. We're putting a plate on either side. It's all connected together. And once we start turning this, these plates are going to separate. And this is what it looks like when we are here we go. So this is what it looks like when we're testing it on the table. So here's the bone. Here are the two plates. The screws are in. Now we're turning it, and see how the bone is separating like this. Okay, we're just making sure that it's going to work okay. Now we're putting it back together. And we're putting it back together because we don't want to do so much all at once. We're doing this a millimeter at a time to give the baby time to form bone. So that's the entire procedure. Pretty simple in concept, very effective in practice. So there are phases of distraction, 3 phases: latency, activation, and consolidation. For parents who are going through this, you'll hear this a lot. And what latency means is once we do the procedure, how long do we wait before we start turning the arm and opening up the distractor a millimeter at a time? And that can vary. What we do here is overnight, so we just do this, and the next day we start turning. When we start turning, that's called the activation phase. And typically we're about 1 millimeter to 2 millimeters a day. 2 millimeters if the baby's intubated, we're trying to get the baby extubated, we go a little faster. If the baby's sort of in the moderate range, we're usually going about 1 millimeter a day. And the stopping point is basically when the airway is open and the baby has a slight underbite. Consolidation means what that means is the amount of time that the baby needs to form solid bone. And it's typically about 3 months. We can go longer, but typically not too much shorter than that. So here's a good photo of the baby that we saw early on in the talk. And this is what he looks like a year after. So you can see like a big difference in where his mandible was, and most importantly, he's not turning blue anymore when he's lying supine. And incidentally, this baby, I have known them for about 4 years, and they are probably the best example of something parents can do for a baby like him. So he was born in Central California, and he had a cleft palate and was referred to UCLA for cleft care. But while he was referred, waiting for his team visit, his mother noticed that he would turn blue all the time, especially on his back. So she tried various things and noticed that if she laid down and had the baby actually face down on her, then he did a whole lot better. And turns out the first thing we see when we see him is pretty clear. He has Pierre band sequence and was admitted relatively quickly, and distraction went forward relatively quickly. But I tell this story because basically she saved his life, because it wasn't completely obvious. He's in the moderate range. He's not super severe, but he's definitely not mild. Okay, so risks and complications. The standard risks of surgery are general anesthesia, bleeding, infection. General anesthesia, of course, in a young baby, small baby, there is a certain risk, but this is a procedure to really help this baby functionally, and we usually accept those risks to move forward. Bleeding, it's not a very bloody procedure. Infection can happen, but pretty rare also. Some pain, some scarring. Injury to the facial nerve. So where we are dissecting, the facial nerve is running through in that area, and so injury to the facial nerve is something that does happen every once in a while. Injury to the tooth roots. Now that's something that happens very frequently, and the reason is because there's not a whole lot of space back there where we're putting in the plates and screws and making the cuts in the mandible. So typically as these kids get older, we do notice that there's some injury to tooth roots. But also something recently coming out that's becoming more and more recognized is that these kids have some dental issues, like dental agenesis. There's some dentition that just doesn't form. Post-operatively, we turn again until the respiratory distress is resolved. A slight underbite, we put a little bit of antibiotic ointment on the turning arms, and actually all the turning is done by the parents at home, except for the acute period while they're still in the hospital. So a lot of this is done by parents, and they do quite well with that. Turning arms are removed in the office, and 3 months later we bring the baby back to the operating room and we take out the distractors. That's also under general anesthesia because we're taking out some hardware. So why are we distracting anyway? It seems like you could do a tracheostomy. You know, is there anything better than this? Well, we actually studied this at UCLA a number of years back, and what we used to do is this conventional method where you kind of took a baby, looked at them, and decided prone positioning if they're mild or tracheostomy if they're not mild. That resulted in about 74% of patients going and getting a tracheostomy. Once we started going through this sort of decision tree process, developing an algorithm that incorporated mandibular distraction, what we found is that still about a quarter of them or so are mild enough that they end up going to just having prone positioning, no operation. 55% of them end up having distraction. Now, tracheostomy dropped down to 24%. And certainly a number of them were still converted from distraction to tracheostomy for various reasons. Maybe they were right on that edge of being able to have distraction versus tracheostomy. But this is a pretty significant improvement in quality of life. Certainly tracheostomies for kids who have it, for parents who have kids who have it, it's real difficult on everybody. It's real difficult to see a kid go through that, having a tracheostomy. Okay, what happens to the mandible long term? So there are two studies that tell us a little bit about what happens. So one was done a long time ago in 1965, and what the authors found at the time was that some of the Pierre kids end up having a normal mandible. Some of them continue to have some degree of a smaller mandible. Some of them are able to compensate for it, meaning that they carry their mandible in a way that it skeletally looks more normal, or also maybe compensating for airway issues. Well, it turns out also, if we were to not operate on these kids, a lot of them continue to have airway issues even beyond the neonatal stage. This is probably the group that is more moderate to mild. So the mandible has some sort of intrinsic inability to grow, normally in Pierre sequence. So a short note on tongue-lip adhesion. I didn't talk about it because we don't really do it, or I should say we don't do it. And the reason is because it doesn't address the core anatomical problem, which is a small mandible. Now what it is a slightly older technique where as the tongue falls back to suffocate the kid, what we do in tongue-lip adhesion is actually pull the tongue forward and sew it to the lip. And the problem here is it doesn't address the mandible, but also it relies on catch-up growth, meaning that the mandible needs to grow in order for this tongue-lip adhesion to then be released later on. And as we know, it doesn't always grow so well, so then it's real difficult to release these types of procedures without having some amount of respiratory obstruction afterwards. And one study that I'll mention briefly is that there's a bunch of reasons in the back of the throat that should also be accounted for, which is where the airway, or I should say the pharyngeal walls, can collapse as part of the airway. And the tongue-lip adhesion doesn't account for all of those, but that is addressed with a mandible distraction. So in conclusion, Pierre sequence consists of micrognathia, small jaw, glossoptosis, the tongue falling back, and airway issues. It's isolated or syndromic. It's very treatable. And the treatment really depends on the determination of what's a reason for airway issues, what's a reason for respiratory distress, what's the severity of reflux, and also if there's multi-level airway obstruction. The internal mandibular distraction has decreased the need for tracheostomy. That's our treatment of choice here, and I'll take any questions now. Oh, I understand that we do have some questions from the internet, so let me take a look here. Okay, so one of the questions that I have here is, when should a mandibular distraction be performed? Well, this really depends on the severity of the baby. So the baby is extremely severe. This is going to happen in the neonatal stage, a few days after life. If the baby's sort of in the moderate stage, mild stage, this can happen a couple of weeks into life. It can happen even like a month or so into life. It just sort of depends on the symptoms. How long is a mandibular distraction procedure? So that's a great question. We distract 1 millimeter to 2 millimeters at a time. Again, very severe. We usually go at about 2 millimeters. We distract it twice a day, so 1 millimeter in the morning, 1 millimeter at night. If it's sort of in the moderate range, we're usually about 1 millimeter a day. So that means 0.5 millimeter in the morning, 0.5 millimeter at night. And we usually go out until the respiratory distress is resolved, and also the baby has a slight underbite. And that typically is about a little over 1 centimeter, maybe around 1.5 centimeters. That's kind of a common number that we shoot for. Is mandibular distraction procedure covered under insurance? Yes, absolutely. This is covered regardless of what insurance you have. As far as I know, I've never had a problem, whether it be public aid, HMO, PPO. This is a functional procedure to help a baby with a congenital issue, and we don't typically have any problems with insurance companies wanting to help babies. All right. And if there are no other further questions, thank you again for joining us for another episode of UCLA MD Chat. My name is Justine Lee, and I'll see you next time.